So we'll just go ahead and get started. So first of all, I just want to say thank you to Dr. Black. I think he can't make it today because he is also presenting at this time, but he did help me with this presentation. So now the objectives for this presentation are to review the pathogenesis of RCC subtypes, to discuss the current and emerging treatment for NCC-RCC, as well as to review the available prognostic factors for patients with NCC-RCC. Now, according to the Canadian Cancer Society, 9,000 Canadians will be diagnosed with renal cell carcinoma or upper tract UCC of the renal pelvis in 2024 alone. And we also expect this year to have 1,950 disease-related deaths just in Canada alone. And RCC represents about 5% of all newly diagnosed cancers in men and 3% of new cancer diagnoses in women. And RCC accounts for 90% of all kidney cancer diagnoses, of which 25% are of non-clear cell histology. And within the NCC-RCC category, papillary is the most prevalent, followed by chromophobe histology. And the next few slides are going to focus on pathogenesis of the various histological subtypes. So even though this talk focuses on NCC-RCC, the pathogenesis of clear cell RCC is important to understand because it relates to some of the drugs we will discuss later on when we talk about the trials. So in normal oxygen conditions, HIF-1 alpha is hydroxylated by binding to PVHL. And then this is followed by ubiquitination and finally degradation. And in hypoxic conditions, the binding of HIF-1 alpha to PVHL is inhibited. So as a result, there is an accumulation of HIF, which then leads to an increase in the expression of genes that control angiogenesis, cell proliferation, and eventually invasion. And the same phenomenon is seen in clear cell RCC when there is a loss of function mutation of PVHL. And other alterations have also been identified, you can see here on the bottom left, and have been associated with either favorable or a poor prognosis. Now, papillary RCC was previously classified as papillary type 1 or type 2. And type 1 was associated to molecular alterations consisting mostly of trisomy of chromosome 7 and chromosome 17. And chromosome 7 is known to have the MET proto-oncogene on its long arm, which, when it's activated, prevents apoptosis, which then leads to oncogenesis. And previous studies have shown that the majority of type 1 papillary tumors exhibit either an alteration or an overexpression of the MET gene on chromosome 7. Type 2 papillary, on the other hand, was known to have multiple driver mutations and both loss and gain across various chromosomes. And an important one to remember is actually FH, or furamate hydratase, which is known to be linked with hereditary leiomyomatosis and papillary RCC. In 2022, however, the WHO released their new classification, which focuses on the molecular attributes of histological subtypes. So the type 1 and type 2 classification was officially retired. Now, the previously known type 1 is now thought to be as the classical papillary RCC, and what used to be type 2 is now separate entities based on molecular alterations. For example, it would be known as FH deficient RCC. Another way to think about papillary RCC is based on its MET status. So this becomes relevant when we talk about the different trials looking at treatment options in the papillary RCC disease space. So you would think about it as MET-driven or MET-independent papillary RCC. Clinically speaking, though, we still get the type 1, type 2 classification in our pathology reports, with papillary type 2 being a more aggressive form of the disease. Now, the oncocytic and chromophobe renal tumors. This classification includes oncocytomas, chromophobe RCC, as well as a new category that's called other oncocytic tumors of the kidney. And this category refers to oncocytic renal tumors with low malignant potential and features between both chromophobe RCC and benign oncocytoma. And it's obviously very important to distinguish here, oncocytoma and chromophobe tumors histologically, because this can significantly alter the clinical course when we perform renal mass biopsies. Oncocytoma will have cells packed with mitochondria under electron microscopy, but chromophobe tumors will have granular pale cells with prominent cell borders and fine reticular cytoplasm, as well as perinuclear halos and wrinkled hyperchromatic nuclei. And chromophobe RCC is known to have both a classical subtype and eosinophilic variant. And with the typical chromophobe having features of both. Now, in terms of the pathogenesis, it's really characterized by mitochondrial gene expression and chromosomal aneuploidy. And when mutations involving TP53 and PTEN happen, we'll see rapid, uncontrolled cell division, which eventually leads to tumor formation. And structural changes involving the TRT gene promoter have also been associated with shorter telomeres, which also have been found to drive oncogenesis. And finally, when you compare it to clear cell RCC, chromophobe is known to have lower somatic mutation rates and a low immune expression, which makes it an overall less aggressive cancer. Translocation RCC is a tumor that will arise in the epithelial cells of the proximal tubules. Clinically speaking, it's a tumor that tends to present in women and younger patients. And in terms of pathogenesis of this cancer, it's thought to be the result of translocation on chromosome XP11.2. This is the chromosome where the MIT gene or MIT genes are located. And these genes are responsible for cell differentiation. And we know from previous studies that overactivation of the MIT family genes has been associated with hereditary RCC. And even though translocation here is the driving mechanism of this cancer, it's also been associated with chromosome 3p loss and others, which make it present similarly to other tumors, and as a result, it can be mistaken for other histologies and can be underrepresented to a certain extent. Now, the SMARCB1 deficient medullary RCC was previously known as simply medullary RCC. Histologically speaking, it originates from the calceal epithelium of the distal nephron. And the hallmark of this cancer is the loss of the SMARCB1 gene, which is a tumor suppressor gene. And clinically, this is a very aggressive form of RCC, which almost exclusively affects younger patients with sickle cell traits, with many cases in the literature affecting people of African descent. And this is the case because renal medullary carcinoma is associated with ferroptosis resistance, which is associated with high levels of iron, which is seen often in patients with sickle cell traits. The next category we'll talk about is collecting duct RCC, which was previously known as Bellini duct carcinoma. It accounts for about 1 to 3% of RCCs, and histologically, it originates in the distal collecting principal cells. It was previously found to be related to mutations involving several genes like the SETD2 gene or the SMAR CB1 gene that we just talked about on the previous slide. In some cases, it is associated also with alterations of neurofibromatosis type 2, otherwise known as NF2. And NF2 encodes for Merlin, which is a tumor suppressor protein. So mutations in NF2 can lead to oncogenesis as well. And when there's a complete loss of the gene, it can cause NF2 syndrome. And finally, the loss of heterozygosity can also lead to early tumor onset, but also poor prognosis overall. So next is sarcomatoid. Sarcomatoid is interesting because it's not its own subtype, but rather a feature that can be seen in any RCC histological subtype. It's thought that sarcomatoid dedifferentiation is related to epithelial mesenchymal transition. And when this happens, epithelial cells lose their epithelial traits and develop mesenchymal sarcomatoid traits. And this will happen when the transcription factors upregulating the epithelial mesenchymal transition process cause upregulation of the mesenchymal markers, but downregulation of the epithelial markers. And previous evidence has shown that the EMTs can also contribute to carcinogenesis, which can potentially explain why sarcomatoid dedifferentiation is usually associated with more aggressive cancers. So the last classification we'll talk about is the unclassified tumors that account for about 2 to 6% of tumors and refers to lesions that share similarities in morphology or in histochemical stains with distinguished histologies. Occasionally, unclassified tumors will have differences that prevent them from being grouped within those classifications. And finally, it's also considered to be a bit of an umbrella term for all the tumors that don't fit in any category or for the tumors that would fit in multiple categories. So briefly here, the CUA has shared a Canadian consensus on genetic testing for patients with renal tumors. And in cases where tumors have molecular alterations involving the MET, the FH, or the furamate hydratase, or the FLCN genes, we should be thinking about the associated genetic syndromes, which are highlighted in the first box here. In the NCC-RCC disease space, we should particularly think about these when you have patients with papillary or chromophobe histology. And then the second table on the right-hand side highlights the various criteria for which you would refer a patient to genetic testing. And on here, I do want to attract your attention to point number 2, which includes our patients with NCC-RCC that today's talks focuses on. Now, according to our Canadian guidelines, the gold standard management for localized NCC-RCC is surgical resection with a nephron-sparing approach when possible. Currently, adjuvant therapy in the form of immunotherapy is not recommended in a setting of non-clear cell RCC, and patients should be monitored expectantly until, if recurrence happens. And in the setting of NCC-RCC, there are no specific recommendations, although some are preferred. And the Canadian and American guidelines recommend clinical trial enrollment, which is sometimes challenging because many of the trials out there that are conducted are for clear cell disease and will often exclude patients with non-clear cell disease. So the next few slides are going to focus on the current available treatments for NCC, RCC, and some of the trials behind them, like the ESPN and the Aspen trials, which were earlier on. And then we'll move on to immunotherapy and NCC, RCC. And then we'll chat about immunotherapy plus target therapy combo. And finally, we're just going to review how all of these trials and others fit together to come up with histology-specific treatment options. So before we get into the trials, we should know and keep in mind as we go through this presentation that the preferred treatment for this patient population is cabozantinib, and this is recommended by the NCC guidelines, but it's also something we have available here in BC. In 2015, the ESPN trial was published by Tanir and colleagues. This was a phase 2 multi-center trial that was an RCT as well, looking at the safety and efficacy of everolimus and sunitinib in the management of patients with metastatic non-clear cell RCC or clear cell RCC with greater than 20% sarcomatoid features. When disease progression happened, they allowed their patients to cross over from one regimen to the other, and both drugs were given on a daily basis, with sunitinib being given on a 6-week cycle basis, where they got 4 weeks of the medication and were off for 2 other weeks. Before we talk about the ESPN trial results, I do want to go over the mechanism of action of these drugs. So as you can see on the left-hand side, everolimus is a selective mTOR inhibitor that binds to the intracellular protein FKBP12, and it forms complexes that inhibit the activity of the mTOR1 complex. And this inhibition will reduce the activity of effectors downstream that then leads to a blockage in the progression of cells from the G1 phase to the S phase. And when that happens, it'll induce cell growth arrest and, as a result, apoptosis. Everolimus will also inhibit the expression of hypoxia-inducible factor, which we know as HIF, leading to a decrease in the expression of the vascular endothelial growth factor, otherwise known as VEGF. Sunitinib, on the other hand, is a multiple tyrosine kinase inhibitor, as you can see on the right-hand side. These are all the tyrosines that it inhibits. And as a result of this, tumor growth, pathological angiogenesis, as well as metastatic progression of cancers are going to be affected. Now, if we circle back to the results of the ESPN trial, they found that the progression-free survival and tumor response in the first line was better with sunitinib. And these results were not consistent in patients who received sunitinib in the second line. In terms of the overall survival benefit, this was slightly higher in the sunitinib group, but in their final analysis, the authors didn't find an overall survival benefit. Next is the Aspen trial, which is an important early RCT in this disease space, and it evaluated the efficacy of everolimus compared to sunitinib in this disease space, and they included only patients with NCC, RCC, and they were trying to fill in the gap in the literature on the optimal initial treatment for these patients, which at the time was not established because other trials conducted were excluding these patients oftentimes. The treatment regimen here was the same as the ESPN trial, and their primary outcome was radiographic progression-free survival, and their secondary outcomes were progression-free survival at 6, 12, and 24 months, as well as duration of response, overall survival, and time to new metastatic disease. Their findings showed an improved progression-free survival in patients receiving sunitinib compared to everolimus, which was consistent with the ESPN trial findings. And the results also found a trend favoring sunitinib in patients falling in the good and intermediate MSK-CC risk stratification. But a trend favoring everolimus was seen in the patients falling in the poor risk category. And patients with papillary and unclassified disease also seem to have a more favorable response to sunitinib when compared to patients with chromophobe histology. And after these two trials came out, sunitinib became the first-line treatment for metastatic NCC-RCC. But this was only until immunotherapy rolled around and was seeing favorable outcomes in patients with clear cell disease. So studies started looking at those same drugs in the non-clear cell RCC setting. So here we're just going to go over the mechanism of action of immune checkpoint blockade. So the activation of T cells first requires an antigen-presenting cell, or here on the image you can see APC, like a dendritic cell, to present an antigen. The APC will present a tumor antigen, which is going to be complex to an MHC class 1, to the T cell via their T cell receptor, or TCR, here on the image. At that point, B7 on the APC will bind to CTLA4 on the T cell that will create an inhibitory signal. But anti-CTLA antibodies can inhibit the inhibitory signal by activating by binding, to the CTLA4. And then once the activated T cell is in the tumor environment, it can recognize the antigen presenting cell in the tumor and lead to cell death. You can also have the programmed cell death, or PD-1 receptor, send an inhibitory signal to the T cell when the receptor binds to the programmed cell death 1 ligand 1, or PDL1. And that is often expressed on tumor cells. So inhibition of the PDL1, for example, with acetuzumab, or PD-1 with pembrolizumab, is believed to block this signal, and that's how those drugs work. The first trial we'll talk about here is Keynote 427, which is a single-arm trial that looked at the efficacy and safety of pembrolizumab, like we discussed, is a PD-1 inhibitor, in the management of treatment-naive NCC-RCC. And here, 165 patients were part of cohort B, with the majority of them having papillary RCC histology. And the primary endpoint for this study was objective response rate, and the secondary endpoints were duration of response, disease control rate, progression-free survival, and overall survival. In terms of efficacy, their objective response rate was 26.7%. And unlike the Aspen trial that we just discussed, they did not see any variability in response based on risk category. They also found that in patients with tumors expressing PD-L1, the disease control rate at 6 months following therapy was 50%. They also reported that their patients' median overall survival was 20.9 months, with a median duration of response of 29 months, which is not terrible for this aggressive disease. And the overall survival at 24 months was 58.4%. Unfortunately, they did also report to treatment-related deaths due to pneumonitis and cardiac arrest. So this next trial is Checkmate 920 by Chakoti and colleagues. It was a multi-cohort trial that included 52 patients with NCC-RCC that were all treatment naive. And the majority of the patients included had unclassified or papillary tumor histology, with about a third of the tumors having sarcomatoid features. The interventions consisted of ipi-nivo combination therapy followed by maintenance nivo. And the primary endpoint was the incidence of serious immune-mediated adverse event, and the secondary endpoints focused on the treatment efficacy. So of the patients included, 2 achieved complete response, 7 had a partial response, and 17 had stable disease. The objective response rate was 19.6% with a time to response of 2.8 months. The median overall survival was 21 months. In terms of safety, they reported no grade 5 adverse events, but they still did report several immune-mediated adverse events like rashes, colitis, hepatitis, and some of the patients did require steroid administration to manage this. But overall, when we look at the numbers and compare them to those of other published studies on IOs, this is fairly consistent. So this next trial by Ghizlane and colleagues is Checkmate 374, and it's a trial looking at the efficacy of nivolumab monotherapy. But this trial allowed the inclusion of patients who had received prior treatment for their disease. They enrolled 44 patients, of which over half had papillary tumor histology. And patients were treated with nivo every 2 weeks until disease progression or toxicity occurred. And their primary endpoint focused on safety, and their exploratory endpoints were objective response rate, duration of response, and PFS. So in terms of their safety outcomes, their findings were consistent with those of the trials we've discussed so far. Their median overall survival was 16 months with a median duration response of 10 months, and the progression-free survival was 2 months. This study also looked at the impact of PD-L1 expression and found that this didn't really affect treatment efficacy, which is contrary to what was reported in Keynote 427. And overall, PD-L1 status was not found to be prognostic or a predictive of treatment efficacy. Now, these 2 trials here, the UNITION trial and the HCRN trial, looked at the efficacy of immunotherapy combination in the setting of NCC, RCC following failure of immune checkpoint inhibitor monotherapy. Both trials looked at the efficacy of ipi-nivo combination therapy. And these are obviously very small numbers, and this should be considered when we interpret this data. But regardless, they found that the objective response rates were very low and ranging from 6 to 10%. And what this suggests really is that only a minority of patients will respond to immunotherapy combination therapy after failure of monotherapy. So not a great option for these patients. Before we move on to the next section, I just want to review some of the IO side effects that we should be aware of as clinicians. So some of the most common ones are fatigue, MSK pain, nausea, or vomiting. But rarer and more severe side effects can also happen, like pneumonitis and colitis. So it's very important to monitor those patients closely when they are on immunotherapy. So next, we're going to be talking about the combination of immunotherapy of immunotherapy and targeted therapy. So the COSMIC-21 trial was published in 2021, and 32 patients with NCC, RCC were enrolled, and all patients had received prior treatment for their metastatic disease, and were treated with the combinations of cabozantinib, which is a TKI, and acetazolamab, which is a PD-L1 inhibitor. And their primary endpoint here was objective response rate as per the RECIST criteria. So of the 32 patients included, half eventually discontinued both drugs due to disease progression, lack of benefit, or just adverse events. And the overall objective response rate was 31%, which were all partial responses with no complete response noted. The disease control rate, however, was reported to be 94%, meaning that the majority of their patient had either a partial response or stable disease. And the highest response rate here were observed within the papillary RCC group, which really begs the question if this combination therapy is best suited for patients with this histological subtype. But obviously, the numbers are very small, so it's hard to draw any definitive conclusions. So this next trial, Keynote B21, was published in the Lancet Oncology just this year. And this was a larger trial which recruited 158 patients with NCC-RCC to assess the efficacy of pembrolizumab and lenvatinib combination therapy. And the primary endpoint here was objective response rate per the RECIST criteria. The authors of this study reported an objective response rate of 49% overall. They have they had 6% of their patients with a confirmed complete response. And in this trial, objective response was observed across all histological subtype, but to a lesser degree in the chromophobe group, which has an overall an objective response rate of 28% compared to the other histological subtypes, which were all above 50%. And the progression-free survival at 12 months was found to be 63%, while the overall survival at 12 months was 82%. And then similarly to the other trials, they reported immunotherapy-related adverse event with 20% of their patients experiencing a severe reaction. And unfortunately, 8 patients died as a result of adverse events. This next section is going to focus on tumor histology-specific treatments and trials. So we discussed earlier in the presentation that papillary RCC has been associated with MET alteration. So as a result, some earlier studies looked at the effect of MET inhibitors as a treatment option for patients with papillary histology specifically. And Choueiri and colleagues shared their first results in 2013 and reported an objective response rate of 13.5%, suggesting that there may be anti-tumor activity. And their following analysis showed that germline MET mutation was highly predictive of response, which was encouraging for the coming trials. So several years later in 2021, Pal and colleagues shared the results of their PAP-MET trial, which was a phase 2 RCT open label study that enrolled 147 patients with metastatic papillary RCC. And these patients were randomized to sunitinib, cabozantinib, crizotinib, and savolitinib. And their primary endpoint here was progression-free survival. So patient basically assignment to Savo and Crizo was stopped earlier in the trial after a pre-specified futility analysis. And in terms of their primary endpoints, they found that patients receiving cabozantinib and had a progression-free survival of 9 months compared to 5.6 months for the patients who received sunitinib, which is quite good. And in terms of response rate, they found that patients receiving Cabo had the highest rate at 23%. This year, the same group published the final results of their SWOG 1500 trial. And here again, data supporting cabozantinib use is compelling, with a median overall survival of 22 months compared to 17 months in the sunitinib group. This overall, their overall survivor landmark at 24 months was 50% for the cabozantinib compared to 39% in the sunitinib group. And I think these trials kind of start explaining why cabozantinib is the preferred agent in these patients. The Savoir trial is another trial that enrolled 60 patients with MET-driven papillary RCC. And patients were randomized to either sunitinib or savolitinib. And the primary endpoint here was progression-free survival, which was 7 months for the savolitinib and 5.6 months for the sunitinib group, which is identical to the data reported by the PABMET trial for those two groups. The objective response rate for the savolitinib group was 27% compared to 7% for the sunitinib group. So overall, both are weaker than the cabozantinib in this histological subtype when we look at the other trials. Finally, the Calypso trial was a single-arm study which recruited 41 patients with metastatic papillary RCC that were either treatment naive or refractory. And patients were given a combination of darolutamab and savolitinib. And their primary endpoint here was a clinical response rate greater than 50%. So they found that patients with a MET-driven papillary RCC, the clinical response rate was as high as 53%. Unfortunately, this wasn't seen in the rest of their cohort, where the clinical response rate was only 29%. In those patients with a MET-driven papillary RCC, the median progression-free survival was 12 months, with a median overall survival of 26 months compared to 4 months when you compared it to the entire treated population, which is quite a significant difference. And overall, this data, I think, is very promising for the use of the savo-durva combination therapy in patients with MET-driven papillary RCC. Now, looking at the specific treatment options for chromophobe RCC, we need to think back to some of the trials we discussed earlier. So close to 15% of patients recruited in the ASPEN trial had chromophobe histology, and those patients were found to have a greater progression-free survival with everolimus compared to sunitinib. So the difference here was 11 months versus 5.5 months. In the ESPN trial, the exact opposite was observed, which really, I think, highlights the variability within histological subtypes and the importance of having larger, robust trials examining those questions. But obviously, with how rare these malignancies are, it is difficult to recruit for said trials. Finally, Keynote 427 showed that there is some degree of response to pembrolizumab with a median overall survival of 23 months, which is not terrible. Now, looking at histology-specific management for collecting duct RCC, we have to almost think about it in the context of its similarities to upper tract UCC. So in this instance, the preferred regimen for this cancer is actually GEM-CIS chemotherapy, which are also the recommendation found in the NCCN guidelines. There was this trial, the Bonsai trial, which looked at the efficacy of TKIs with cabozantinib and found some encouraging results with this drug, with an objective response rate of 35% and a progression-free survival of 4 months. So with more research, this could potentially represent also an option for these patients. Now, briefly on prognostic factors for non-clear cell RCC. So we know that in metastatic RCC in general, the MSK CC and the IMDC model, which you can see on the right-hand side here, have been validated. Now, looking specifically at metastatic NCC RCC, Kroger and colleagues in 2013 also validated the use of the IMDC model as a prognostic model in this disease space. So this is one model that we can certainly use for these patients. But there's been some research looking at the immunoscore as a potential prognostic factor. So this is used in colorectal cancers, mostly in patients with stage 1 to 3 colorectal malignancy. And it essentially quantifies the lymphocyte population within the tumor and around the tumor in its environment. And based on the immunoscore, patients are stratified based on the likelihood that they will respond to immunotherapy or combination therapy. This was actually investigated in 2021 by Selvi and colleagues in the non-clear cell RCC disease space, but it was not found to be a prognostic factor in for those patients in metastatic NCC-RCC. So to conclude, metastatic NCC-RCC is a highly aggressive disease with limited effective therapies, and patients should be enrolled in clinical trials when available. The studies reviewed today really highlighted that the underlying tumor histology can play a really important role in treatment response. And moving forward, we also need larger trials to help establish optimal treatment based on histological subtypes. And finally, prognostic factors in this disease space are quite limited, and the IMDC is a validated one that we should continue to use. And that's all I've got. I'm happy to take any questions.